Thanks so much, Elizabeth, and thank you everyone for joining this afternoon or this evening, depending on your time zone. As Elizabeth said, my name is Deanna Saylor, and I'm excited to be able to talk to you today about the work that I've been doing in Zambia for the past 4 years. And I'm actually coming to you from Lusaka, Zambia this evening. So my talk today is called Addressing Neurological Diseases in Zambia and focusing on developing inpatient services and training programs in neurology. So first, just to frame our discussion, I wanted to talk a bit about global neurology for those that might be less familiar. And the reason that I think it's important to think about neurology in the global context is that the Global Burden of Disease study has shown us that neurological disorders are the leading cause of disability-adjusted life years worldwide, and they're the second leading cause of mortality globally. But this burden is not distributed equally. So 75% of the global burden of neurological disease is in low and middle income countries. Yet these same countries have the smallest neurological workforce to care for these patients. And I particularly like this quote from the executive summary of the World Health Organization's Atlas of Country Resources of Neurological Disorders, where they say there's a growing recognition that the burden of neurological disorders is disproportionately high in low and middle income countries, where healthcare services and resources are often scarce. Importantly, the neurological burden of disease is expected to grow exponentially in the next decade, with the highest growth in this burden in low and middle income countries. And so we know that the number of neurologists does not match the burden of neurological disease. But to look at this in more detail, we can look at this graph here, which shows that in high income countries, there is over 6 neurologists per 100,000 people. And when you compare that to low and lower middle income countries, this number drops to 0.03 or 0.13 neurologists per 100,000 people. If we look by world region instead, you can see that Europe has more than 6 neurologists per 100,000 people, whereas in the African region, that number is 0.04. You can see that the Southeast Asia region also has a very low ratio with 0.1 neurologists per 100,000 people. In the US, this number is more than 5 per 100,000 people, and in Zambia, where I'm based, the number is 0.02 per 100,000 people. So unfortunately, there's also very few neurology training programs in many low and middle income countries, and this is especially true in sub-Saharan Africa. So this data is quite old, it's not been updated, but it was from a prior version of the WHO Atlas. And this map shows any country that's in blue had at least one neurology training program in the country. Countries that are in pink had no neurology training program, and then countries that are in white had no data available and probably had no neurology training programs. And so if we look here specifically at sub-Saharan Africa, you can see that most countries had no neurology training programs. And without neurology training programs, then that means that there's unlikely to be a significant improvement in the ratio of neurologists per population. And so if we shift gears now and focus a bit on Zambia, we do know a bit about the neurological disorders that we see commonly in Zambia. And this is primarily from a project that was led by Aparna Nutaki, who's now a 4th-year medical student at Rush University in Chicago. She spent 1.5 years working with me here in Zambia, and her first project was to complete a comprehensive clinical registry where we collected data on clinical presentation, exam findings, laboratory and imaging results, diagnoses, and outcomes of all patients who were admitted to our new neurology inpatient service over the first 6 months of its existence. And so the first thing we found was that we were incredibly busy. So we're the second busiest service in our hospital with about 125 admissions every month. And we found that our admissions were almost equally split between patients coming in with stroke and those coming in with non-stroke neurological disorders. And when you look at the demographics of these two groups, we see that these are really two entirely different cohorts. So our patients with stroke are much older with an average age of 60 than our patients with non-stroke disorders who had an average age of 42. Also, women are disproportionately represented in our patients with stroke, with 62% of our strokes happening in women, as opposed to only a third of non-stroke disorders. We also see that patients with non-stroke disorders were more likely to have HIV. 27% of these patients had HIV, compared to a little less than 20% of patients with stroke. And then the other thing that's quite astounding is that our mortality rates are pretty high. So almost a quarter of our stroke patients die in the hospital, and a little under 20% of our non-stroke patients. So I think this really represents several things. One is the severity of illness with which patients present. We often see late presentations, and also the limited treatment and diagnostic modalities that we have to care for these patients as well. When we look at the non-stroke presentations, you can see that this really is predominantly accounted for by patients presenting with seizures and neuroinfections, and then essentially a smattering of lots of other types of neurological disorders as well. When we look at stroke, we see that it's not just that we have a high burden of stroke, but it's the type of stroke that we have as well. So when we think about stroke, stroke is divided into two primary categories: ischemic strokes, where there's a blockage of blood flow to the brain, and hemorrhagic strokes, where a blood vessel ruptures in the brain. And in general, patients with hemorrhagic stroke have much worse outcomes than patients with ischemic stroke, with higher mortality rates. In most high-income settings, 80 to 90% of strokes are ischemic strokes, and only 10 to 20% are hemorrhagic strokes. And that's primarily because the primary risk factor for hemorrhagic stroke is uncontrolled hypertension, and hypertension tends to be better managed in high-income settings. What you can see here is not only do we have a high burden of stroke, but we have a high percentage of patients with hemorrhagic stroke. And so these patients are sicker and have worse outcomes as well. You'll also see that 14% of our patients are what we call unknown stroke. And this is because the only way to definitively differentiate an ischemic and a hemorrhagic stroke is through neuroimaging with either CT scans or MRIs. And our patients sometimes don't have access to neuroimaging. This can sometimes be because our scanners are not functioning and we don't have access for any patients, or because patients have to pay for the scans before they can happen. And so sometimes very sick patients die before the family can raise money for this, or because they're just never able to raise the money during their hospitalization. And so again, if you look here at the mortality rates in each category of stroke, we see that our mortality rate for ischemic stroke is 18%, hemorrhagic stroke is 33%, as well as unknown stroke was 33%. And so again, these mortality rates are higher than what you see for the same diseases in the same types of stroke in high income settings, but they do reflect that hemorrhagic strokes have a much higher mortality than ischemic strokes. So into this setting, we came to Zambia about 4 years ago. And just to orient everyone, Zambia is a country of almost 18 million people in Southern Africa, 75% of whom live on less than $1 a day. It does have the seventh highest HIV prevalence in the world, with an HIV prevalence of about 12%. And if you just let that sink in, that means that 1 out of every 8 adults that you encounter on the street is likely to have HIV. In addition to the HIV burden, it is one of the 30 high TB burden countries in the world as well. And for this, again, this data is a bit old, but hasn't been updated. There's far fewer doctors than the recommended minimum number of doctors per population. So about a decade ago, there were just over 800 doctors, where the WHO recommended minimum number for the population would have been 2,300. So there's far fewer doctors than would be recommended. And then this is also happening in the context of these two epidemics with HIV and TB, and then a growing burden of non-communicable diseases, just as we're seeing in most lower resource settings. When I arrived in Zambia in 2018, there were 4 expatriate neurologists, 3 of whom were predominantly doing research, and I was the only one that was primarily focused on clinical care here. So I began working at the University Teaching Hospital, which is based in the capital city of Lusaka. It's the largest hospital in Zambia, and it has over 1,600 official beds. And this doesn't include patients that are sometimes cared for in the aisles and extra beds that are put into the wards. And just for reference, Hopkins is a pretty large US hospital and has less than 1,200 beds. So this is a really massive hospital with lots and lots of patients. It is the National Referral Hospital and the primary teaching hospital in Zambia. So it really hosts the vast majority of postgraduate training programs, or what we would call residency programs in the US. And when I arrived in 2018, there was no neurology inpatient service at UTH or anywhere in Zambia for that matter. And so neurology patients were cared for in the internal medicine service. Yet what we needed to really care for patients with neurological disorders was present. So UTH does have 2 CT scanners that usually at least one of them is functional. We do have an MRI machine as well. It does have for sometimes prolonged periods where it isn't functioning, but we do have access to it a lot of the year. We have our own EEG lab, which is a test that we use to look for seizures. We also have an EMG lab, which is a test that we use to diagnose disorders of the peripheral nervous system. And then we have the equipment to do lumbar punctures, which is where we stick a small needle into the back and remove spinal fluid, and we can send that to the lab to diagnose infectious and inflammatory disorders of the nervous system. So we had the basic tools that would be necessary to care for these patients. And so when I arrived, I started the first neurology inpatient service. Initially, the inpatient service was starting before the neurology residency had started. So I was essentially given a couple of internal medicine residents and told that all of the patients that were spread out over these 8 wards where our patients are cared for that had neurological disorders were now mine to care for. So just to give you some context, this is a picture of the medicine block at UTH. So each one of these floors represents a ward, and these tend to be big open wards where there's multiple beds, and then we have some curtains that we can pull down to try to give privacy for patients as well. You can see that all of the patients here have what we call a bedsider. This is a family or friend or some sort of caregiver that sits at the patient's bed, usually 24 hours a day, to provide basic care for the patient that we would think of as kind of nursing care that in the US that's provided by nurses or techs. So things like bathing the patient, feeding the patient, assisting with those daily activities. And here's a picture of us on rounds. We often have visitors from the US joining us. We have medical students joining us. And then we have neurology residents that are helping us to care for these patients. So there are certainly many challenges. I've alluded to the fact that our patients are incredibly sick and that we have limitations in both the diagnostic tests that we have as well as the therapeutic options that we have. And so some days you just feel like you don't have the right tools for the situation, and you may even end up protecting your picnic from an ostrich with a plastic chair. But we persist anyway, and it's been a really rewarding experience to build this. But I think the most rewarding experience has been building neurology training in Zambia. And just to take a step back and think about why it was important to set up neurology training, I think that it's really important to train specialists in their home countries. And the reason for that is that the disorders that I'm caring for in Zambia are quite different than the spectrum of neurological disorders that we commonly see in the US. And so training physicians in the country where they're going to practice means that they're training based on the most common disorders that they're going to see. In addition, it means that they're training within the resource constraints that are occurring in that setting. So obviously the resources that we have at a place like Johns Hopkins to care for patients are quite different than the resources that we have at UTH. And the way we approach our clinical care is quite different. And so training people within that same environment means that they learn how to approach patients and maximize the resources that they have rather than focusing on the resources that are unavailable. And then, of course, if you train people in their home countries, they're more likely to remain in their home country, as opposed to the risk of what is termed brain drain when people go to a higher resource setting for training and then may not return to their home countries. And so I think that in-country training is a way to really build local expertise and to make sure that that local expertise is really expert on the types of conditions that they're going to see and the types of resources they're going to have available. So this is a picture of our first group of neurology trainees that began neurology training with us back in October of 2018. These two women in black in the middle were our first pediatric neurology trainees. This is Infama Kawatu and Lisa Nkole. And then the other three were our first adult neurology trainees. So we have Stanley Zimba, Lorraine Chishimba, and Mashina Chamba. And when I was designing the curriculum for our new neurology training program, there was really a lot of opportunities that I thought were quite unique. So the first thing was that I was designing a training program from scratch in a country that had never had a neurology training program before. And so there were really no preconceived notions about what neurology training was supposed to look like. This meant that I got to think about my own training and what I liked and what I didn't like and try to improve on that. And also implementing a training program in a country with a different typical training structure meant that I got to take the strengths of traditional Zambian postgraduate training and mix them with the strengths of traditional US postgraduate training. So for example, in Zambia, didactic lecture time for trainees is really well protected, and there's an emphasis on making sure trainees have the opportunity to attend. Whereas in the US, when I was training, our didactic time was often interrupted and not protected. On the other hand, in the US, when I was training, there was a heavy emphasis on clinical training and clinical reasoning taught to you by your experts. And that, I think autonomy is more emphasized in traditional Zambian postgraduate training. And so I was able to kind of combine those two strengths. And then just in general, in Zambia, residency training is considered a master's degree program. And so there needed to be formal courses and assessments, which is quite different than how neurology training or residency training is in the US. So overall, our structure mirrored other specialty training programs within internal medicine in Zambia, where our residents do 3 years of internal medicine postgraduate training and then 2 years of neurology training. This is in comparison into the US, where residents do 1 year of internal medicine training and 3 years of neurology training. And finally, I really wanted to intentionally create an academic and research focus within our program. I did this by including weekly journal clubs, research method seminars, and emphasizing scholarly activity. And the reason that I really wanted to do this was because I recognized that we were creating a new field of medicine, and I wanted in Zambia, and I wanted our graduates to have the resources necessary to develop their own locally relevant data that would inform how they cared for patients, their policy and advocacy activities with the Ministry of Health, and really enable us to develop our own evidence-based systems of care. And so our trainees have really stepped up to this. They've had oral and poster presentations at multiple national, regional, and international conferences. This is our now graduate, Dr. Zimba, presenting at the American Academy of Neurology a couple years ago. So probably my proudest moment in my career so far was a year ago when our first group of trainees graduated, and we're really able to continue educating and training more people. So now all of our first group of graduates are now junior faculty in our program. And I always tell them that my goal is to make myself obsolete by training enough people that they can continue to grow and take on leadership roles and really take over the program so that it is sustainable locally and not reliant on external support. You can see some of our current trainees as well. We have Dr. Moses Mata and Dr. Frighten Mutete, who are some of our current trainees. And we do think that we'll end up graduating about 15 neurologists over the first 5 years of our program. And just briefly, we've accomplished a lot, but I still have a lot of hopes for our program. So as far as clinical innovations, we've actually implemented 2 different teleneurology services during COVID. One focused on our vulnerable population in our outpatient clinic, where we're really using telephone-based services because these patients don't really have access to the internet. And then one Zoom-based teleneurology program with a private hospital in a remote part of the country that has a hard time getting their patients to us. We're developing a tele-EEG service where we are going to have EEG machines at provincial hospitals. Again, this is used to help diagnose epilepsy, and we'll train technicians at those hospitals to perform the tests, and then we'll read them centrally from our department. And we're working to develop a stroke center. So we know that having stroke centers in the US has led to better outcomes for patients with stroke. The guidelines for these are really focused on high income settings with lots of resources. So we're in the process of developing an evidence-based low resource stroke center where we adapt those guidelines to our local environment. We have taken our didactic curriculum and are now offering it virtually on Zoom. Initially, this was done in the setting of COVID, but we've actually just opened this up to anybody who wants to join from across the region, and now have people regularly joining us from Ghana and Nigeria and Uganda and Kenya and Tanzania. And so we're really able to leverage that. We're about to undertake a formal program evaluation so we can understand the impact of our program from multiple stakeholder perspectives. And we're also working to revamp the medical student neurology curriculum as well. We have lots of exciting research going on, including stroke studies on multiple sclerosis, neurosyphilis, neurocysticercosis, palliative care, epilepsy, dementia, really the range of neurological disorders. And these are primarily being led by our current and former trainees and recent graduates. So this has been a whirlwind overview of the work that we've been doing, and I would be remiss without really acknowledging all the people that have contributed to this. So first and foremost, my colleagues within Zambia have been the reason that this program has been so successful, but also I've had a fantastic group of mentors who've really put me in a position to do what I'm doing today. We've had a lot of support from various funders as well, including the NIH, the National MS Society, the Encephalitis Society, the Ministry of Health in Zambia, and the University of Zambia. And then the Fulbright program was the initial sponsor of my first 2 years in Zambia as well. So I'll stop here, and I'm happy to take any questions and open up the conversation.
Thank you so much, Dr. Saylor. That was wonderful. So we do have a couple minutes for questions. If anyone would like to ask a question directly, feel free to unmute at any time, and I will make sure you have the chance to talk. I can look and see who has unmuted. I can go ahead and kick us off with the first question. Can you share more about how you recruited trainees and built buy-in for the program?
That's a great question. Our first group of trainees were sort of handed to me. So these were people who had had an interest in neurology training over several years, but just hadn't had the opportunity. And so they were sort of waiting for the opportunity to train in country. But then, the rest of our trainees have really transferred from the internal medicine program to our program. And this has really been based on just having exposure to neurology. And so I think before you have a neurology training program and before you have neurologists with a large clinical presence, that means that medical students, internists, they're being taught neurology by non-neurologists. And so they're not really getting the type of really high level exposure to neurology. And so just having a neurology presence has really encouraged a lot of people to transfer to the program and begin training with us just because they were exposed and found out that it was something that they enjoyed and were excited about.
Thank you. And how did you identify this university teaching hospital as the place that would make the most sense to start the program?
Yeah, that's a longer story, but the very brief version is that I had worked in sub-Saharan Africa, primarily in research capacities in Kenya and Uganda for many years. And I was always struck that while I thought the research that we were working on was really important, that when we left those areas, there was no neurologist to take care of those patients. And so it really was within me, even when I finished neurology residency, that what I really hoped to do was to build neurology training in a country that didn't have neurology training. And then as far as Zambia was concerned, it was really kind of a confluence of meeting people. I was able to meet some American neurologists that were based in Zambia, primarily doing clinical research, but they had recognized the need for a training program, but didn't really want to be the ones to do the actual training. And so they, though, had the bureaucratic connections within the University of Zambia and the Ministry of Health to get buy-in from them. And this also happened to occur at a time where Zambia was developing an emphasis on increasing the specialty training programs that were available in country. And so really kind of all of that came together to allow neurology training to get support from the Ministry of Health and the University of Zambia. And then my own research interest was in neuro-HIV. And so I did know that I wanted to be somewhere in sub-Saharan Africa. So Zambia worked well for us, and it's a beautiful, peaceful country. And so it was a great place to move our family to as well.
Takes a lot of buy-in to build a program like this. And it sounded like you chatted with a lot of people.
Yes, for sure.
Reminder to the audience, please unmute at any time if you have any questions. I can definitely keep going if people just want to sit back and listen to a conversation. Deanna, can you tell us a little bit about the maybe conversation that's happening on the community level around like preventative measures? So you mentioned, of course, that hypertension is an indicator for stroke, or the possibility of stroke. Is there a conversation about how to prevent hypertension or to manage those, even in a lower resource setting?
Yeah, I mean, I think that there's a lot of emphasis now on how to strengthen the primary healthcare system within Zambia. I think, unfortunately, the past year and a half has just derailed a lot of non-COVID efforts everywhere in the world, but I think that's been especially true in lower resource settings where COVID has sort of drained resources from other initiatives. But I do think that there's a recognition that the primary healthcare services need to be strengthened, not just for stroke prevention, but for diabetes prevention and management, all of these non-communicable diseases that are now emerging and really require chronic care. And I know that Zambia, like a lot of countries in sub-Saharan Africa, are exploring ways that can be integrated into HIV care models, which is really the kind of the pillar of longitudinal care in most of sub-Saharan Africa. I certainly think from our perspective, just controlling hypertension would significantly reduce how busy we are, because it is such a contributor to the stroke burden, and the stroke burden is so much of what we see. And so certainly it's great to have specialists that can react to these problems, but strengthening the primary health services so that we can prevent them, I think, is even more important.
Absolutely. So we are at 3:30. So I'll invite Dr. Saylor to, if you have a final comment to wrap up today's session, that would be great. Okay, just a hand clap. So any final comments, Dr. Saylor?
Yeah, I think I think that training is so important, that when you train people, you're not just, when you care for people, you're impacting the lives of those that you care for. But when you train people, you're training them to then go on and impact the lives of so many people that they're going to care for as well. And so I think training and mentorship has certainly been important in my career. And I think the greatest legacy we can leave is the people that we train, and really dedicating yourself to training and mentoring other people is so important in any setting, but especially in low resource settings as well.
Well, thank you so much. And I'm so happy to hear that you have graduated your first cohort and they're all back as assistant faculty, which is great to hear. So that wraps up today's session. Thank you all so much for being here, and I hope to see you at a future event, maybe even tomorrow when we have another spotlight. Rare that we have 2 in 1 week. So I hope to see you all soon. Thank you so much.